Good day, everyone, and welcome to today's webinar. I'm Jessica Hodge, and I'm your host for today's webinar, which is the 8th webinar in Healthcare Excellence Canada's discussion series, Community Dementia Care and Support, Innovations Supporting People Living with Dementia and Care Partners Closer to Home. We are pleased to offer French simultaneous interpretation on today's webinar. If you would like to see and hear the presentation in French today, and you have not yet been transferred, you can let us know in the chat box on the bottom right of the screen. Once you have been transferred, you will need to shut down your computer speakers and dial the number on the screen. We also invite you to share your questions and comments at any point using our chat box in either English or French. We will reserve verbal discussion of comments and questions to the end of the webinar, but encourage all of you to respond and comment and answer questions in the chat as you wish as we go along. Also a note that we will summarize the chat questions and comments after the webinar and translate this to both official languages for sharing in a post-webinar synopsis. Our participants for today include representatives from across Canada. We are joined by representatives from regional health authorities, universities, Alzheimer's Societies, research centers, Dementia Advocacy Canada, ministries, Canadian Agency for Drugs and Technology and Health, Canadian Institutes of Health Research, Health Canada, the Public Health Agency of Canada, community support organizations, dementia care organizations, retirement and long-term care homes, the Centre for Aging and Brain Health Innovation, AgeWell, the Canadian Frailty Network, the Canadian Medical Association, the Royal College of Family Physicians, and government health departments across Canada. Before we go further, I want to begin this webinar by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, we acknowledge that I am hosting this webinar from Perth, Ontario, which is the traditional territory of the Anishinaabe, Huron-Wendat, and Haudenosaunee St. Lawrence Iroquois peoples. This territory is covered by the Upper Canada Treaties. I encourage you all to share in the chat box the territory and land you are joining us from today. Our Hep team involved in creating and producing this webinar series includes Neil Dreimer, Nicole Pollack, Emily Lalonde, and myself, Jessica Hodge. My colleagues, Sheena and Dalal, are behind the scenes producing the webinar. Our presenter today is Dallas Seitz. Dallas, would you like to introduce yourself?
Oh, hi there. My name's Dallas Seitz. Can you hear me okay?
You're great. We can hear you.
Great. Thanks for everyone for being here today. I'm a geriatric psychiatrist at the University of Calgary and a scientist in the Hotchkiss Brain Institute.
Thank you, Dallas. We also have our session moderators, Mimi Lowy Young and Mary Beth Whiten, who will lend their expert perspective to the information presented and to the comments and questions you enter in the chat. Mary Beth, over to you to introduce yourself.
Hi, Jessica. I'm Mary Beth Whiten. I'm 52 years old and I have a diagnosis of probable frontotemporal dementia. I'm the co-chair of Dementia Advocacy Canada, which is a grassroots group of Canadians living with dementia and care partners, and on a lot of other different cross-cutting initiatives. And I'm quite excited to hear Dallas and his discussion today. Thanks.
Thank you, Mary Beth. And Mimi, over to you for a brief introduction.
Thank you. Good afternoon and good morning to everybody. I'm Mimi Lowy Young, and I've been a health executive for over 40 years. Most recently, I'm the former CEO of the Alzheimer's Society of Canada. Currently, I'm the chair of the board of directors of AgeWell NCE Inc. I'm also a senior fellow at the Institute of Health Policy Management and Evaluation at the University of Toronto. Welcome, everybody.
Thank you, Mimi. Thank you to all our presenters and moderators for being here today. So now I'd like to talk a bit about the objectives for today. So our first objective is to provide an overview of HEC's Community Dementia Care and Support webinar discussion series. broaden awareness and discuss PC data, and facilitate a discussion around the potential spread of innovations to improve care and supports in the community for people living with dementia and care partners. Now, I'd like to talk a little bit about Healthcare Excellence Canada. So Healthcare Excellence Canada is an organization with a relentless focus on improving healthcare with and for everyone in Canada. Launched in March 2021 from the amalgamation of the Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement, Healthcare Excellence Canada has greater capacity to support partners to turn proven innovations into widespread and lasting improvement in patient safety and all the dimensions of healthcare excellence. We believe in the power of people and evidence and know that by connecting them, we can achieve the best healthcare in the world. HEC is an independent, not-for-profit charity funded primarily by Health Canada. Our community dementia discussion series will broaden awareness and discuss innovations that aim to improve timely diagnosis of dementia in primary care and post-diagnostic supports, including coordination and navigation. To find more information about the topics and webinar dates, you can visit our webpage on the HEC website. If you know about an innovation that could spread across Canada that improves timely, compassionate dementia diagnosis in primary care or coordination and navigation of post-diagnostic care and supports that would work in the COVID-19 context, please email us at the email provided on the screen to let us know. For your consideration today and throughout the series, what promising innovations exist that could be spread across Canada, including in the COVID-19 context? What is the feasibility of your organization and or community to implement and spread the innovations? Where can Healthcare Excellence Canada add value to support a multi-jurisdictional approach to spreading these innovations? And what are the partnership opportunities to help spread innovations to improve community dementia care and support? Now I'd like to take a couple of moments for some reflections, and so I'll ask Mary Beth and Mimi a question. Mary Beth, how can we improve the well-being of people living with dementia and their care partners, specifically related to improved compassionate diagnosis and immediate access to supports?
Thank you for the good question there. So just to remind people, in 2012, I was diagnosed with probable frontotemporal dementia. And that experience left me scarred and frankly angry. And as I began to speak with other people with dementia, we each talked about the terrible experience of being diagnosed with a lack of compassion. And then, following that lack of compassion, a lack to immediate access to supports or even supports itself at any time. So I find it actually quite frustrating that we're still talking about the same issues. And I've asked myself, what has changed in the past 8 years since I was diagnosed that has truly impacted people with dementia and that has resulted into drastic change or even just change and resulting to improvement in this area that we're talking about. And I think one of the things we need to do is take a step back, and I believe we need to address this question in terms of a human rights approach, and in particular as it relates to the Convention on the Rights of Persons with Disabilities, or the CRPD. And this then would line up with the Canadian National Dementia Strategy that has human rights as one of its principles and something that we fought very hard to get on as a principle. So the person with dementia must be seen as someone with rights who still has much to contribute to society. And this would mean then providing individualized, responsive, flexible social and personal care services. And then what's important is to have those underpinned by values respectful of the individual rights and the autonomy, and therefore maximizing his or her well-being. It would mean a commitment to make services flexible, responsive, and timely, and it would involve listening to the desires, preferences, and needs of people for whom the service is being provided and adjusting those supports being offered to help them in what they value the most. I think it needs to be etched into each GP who is providing a diagnosis that once that diagnosis is made, how the news of dementia is conveyed to the individual and the support offered by the GP will greatly influence how that person ultimately will cope with the disease. So if we take the Conventions on the Rights of Persons with Disabilities, Article number 9, and the description of that is healthcare services and information must be accessible to people with dementia. The question is, does Canada do this for each person that is diagnosed? The answer is that no. CRPD Article number 25 states, enjoyment of the highest attainable standard of health without discrimination guarantees persons with disabilities the right to the highest attainable standard of health on the basis of, without discrimination, on the basis of disability, including access to the same range and to the quality of health service as the rest of the population. And the question here is, does Canada do this for each individual with dementia? And once again, the answer is no. So I think really, when we review this, we have done this for cancer. The diagnosis of cancer has become much more compassionate. We can do this for dementia as well. The question is, when are we going to provide people with dementia a compassionate diagnosis with immediate access to supports? And I question how much more research is needed before we attain the Canadian National Dementia Strategy objective, which is to improve the quality of life of people living with dementia and caregivers. So I've been waiting for 8 years, and I think I need to ask, how many more will I wait until a systemic change happens in our medical community and outside our medical support community with forcing it to comply to the human rights of people with dementia? Thank you.
Thank you, Mary Beth, for sharing your experience. Mimi, I'd now like to ask you a question. When could a virtual solution help support diagnosis for people living with dementia?
Thank you very much for the question, and to reiterate some of the issues that Mary Beth has raised, they are critical to the well-being of people living with dementia. What I'm going to offer is some practical solutions to some of the issues that Mary Beth has raised. There are opportunities for virtual solutions through multiple points in an individual's journey through dementia. For example, we refer to, and this is through AgeWell NCE, to what we call serious gains that can show a decrease in response times when that could indicate early onset of cognitive decline. Anybody, and Mary Beth alluded to this, anybody or a friend who's gone through a memory test, it's a very stressful process. AgeWell research teams are hard at work on finding new ways to monitor cognitive health and detect changes by using tests that are enjoyable, such as, example, virtual whack-a-mole game. And the early diagnosis can be made. If some of you were on our December webinar, we talked about Winterlight Labs. AgeWell supports a startup who's developed a technology that can monitor cognitive health through natural speech. The tool records short samples of a person's speech by describing a photo on a screen. In the lab, the platform can reliably identify Alzheimer's disease, Parkinson's disease, and aphasia between 85 and 100% accuracy. The company is testing its proprietary natural speech analyzer to define its effectiveness as a clinical decision support tool. So there are solutions out there that can and should be, once we get the research out and begin to spread and scale, these innovations can support effective diagnosis of people living with dementia. Thank you.
Great. Thank you, Mary Beth and Mimi, for those reflections. You've given us quite a bit to think about and ponder on. I'd now like to turn it over to Dallas, who's going to give us a presentation on PC data. Dallas, over to you.
Great. Well, thanks, everyone, for the opportunity to present and the great context for today's webinar. I'm going to be presenting on a project I've been working on for some time called the Primary Care Dementia Assessment and Treatment Algorithms, and review both the original project, which involves some clinical care pathways, and then the recent development of an online course. And for those of you who just joined, I'm a geriatric psychiatrist at the University of Calgary. In terms of disclosures, this project was supported by a grant from the Canadian Institutes of Health Research, and I should acknowledge that the content we created in our research project has been licensed under a proprietary agreement with ICI Medical for the development of the online course, and I'm a shareholder in the company that holds the intellectual property for the materials I'm going to be talking about. So just to touch briefly on dementia best practices, and I think this sort of comes back a bit to Mary Beth's comment about, this information about what we should be doing to support people living with dementia and their care partners. I think we've got really good evidence of the things that seem to help and the processes and approaches that we should be taking. And in Canada, we actually have some really good guidelines on the diagnosis and treatment of dementia. These go back over 20 years now, and they're updated periodically, including just this last fall. And they're quite comprehensive guidelines. The most recent, more recent updates in 2007 included 146 different recommendations related to guideline recommendations that were sort of spread over 178 pages. And our most recent guidelines, which are just have been published in summary form and are going to be published in full format this coming spring, have over 88 recommendations for people with dementia. So we do have a lot of, I would say, good quality evidence of the things that we can currently be doing that are helpful or may be helpful for people with dementia. And our guidelines also state that primary care is really a key part of dementia care. That's where most people will receive their diagnosis and where most people receive the bulk of their care. And our guideline recommendations acknowledge that most people can be assessed and managed by primary care clinicians, I would say not just physicians, that all clinicians caring for people with dementia have to have some core knowledge and skills. And there was also recommendations in the 2007 guidelines about having an education program to promote adoption of the guideline recommendations. We do know that two of the main features that can help improve the quality of care for people with dementia and their care partners are a combination of dementia education programs and also having access to dementia resources or dementia experts who are connected to primary care, often referred to as dementia care managers. So our project, PC Data, was initially funded by the Canadian Institutes of Health Research, and the overall objectives for the project were to develop some knowledge tools to facilitate the assessment and management of Alzheimer's disease and related dementia by primary care providers based on our guideline recommendations. And the initial project was implemented in Ontario, where I was working up until 2019. although we've also done some implementation of these tools in Saskatchewan with my colleague Dr. Deborah Morgan, who I think is on our presentation today, and also more recently developed an online format for our tools. So in terms of the development of the tools, in addition to the guideline recommendations, we also did a literature review in terms of key challenges that primary care had reported having in terms of assessing and assisting people with dementia. We also worked with primary care providers as part of our project team. We also conducted literature reviews and also our own focus groups with persons living with dementia and caregivers to understand both the local context in Ontario for the project, but also to ensure that the tools and approaches incorporated their perspectives and experiences. And then we pilot tested the tools with primary care providers. So just to speak a little bit as to some of the qualitative research that went into our project, we published a few papers related to this. One summarizing the existing literature that was published both within and outside of Canada on the left there, showing that the process of receiving a diagnosis can be challenging and that there are health service implications at sort of each step of the diagnostic phase. In our own local focus groups, we also had similar themes that arose, but also some specific challenges. And one of the illustrative quotes from our paper was, "I shouldn't have to push and fight," which was how one person described their journey with trying to understand what was going on with their memory and thinking and to arrive at a diagnosis or an understanding of what was causing that. Using this information and also other chronic disease management models, we developed 3 algorithms to really serve as sort of anchors around the key processes that should be followed in the evaluation and management of dementia. These 3 algorithms, the first one was based on the evaluation of someone who may be at risk or exhibiting symptoms that might indicate a dementia or some form of cognitive impairment. A second algorithm based on how to initially disclose the diagnosis, support, and implement treatments for dementia. And then a third module, which was on some of the more challenging aspects of dementia care, including things like driving, behavioral changes, capacity, and issues related to household safety. Modules 1 and 2 were incorporated into our online course, which I'll talk briefly about at the end. We also developed brief visit flow, what we referred to as cheat sheets, to assess the patient assessment. So these were very simple tools that could sort of serve as reminders when a primary care physician or a nurse practitioner was assessing someone for dementia to sort of distill down the key questions or things they may want to assess for. We also developed a manual which contained detailed information and electronic copies. And this was anchored in an education program, so there was also a series of slides that was the way that we implemented our learning. We also, of course, didn't reinvent the wheel. We tried to incorporate as many common evidence-based tools into our education programs as possible, things like the AD8, MOCA, or other cognitive assessment tools. So just as an example, this was our evaluation algorithm, which again just serves as a high-level overview of the key steps, starting at who should be assessed for cognitive complaints, how might you administer and interpret a cognitive screening test. And again, it doesn't have to be the MOCA, although that was one of the tools that we recommended in our screening. There are others available. And then sort of working through sort of the assessment process in terms of investigations and history that you would go through to see if someone may have a dementia, or maybe it's mild cognitive impairment or normal aging or another condition. This is an overview of the second pathway, which is really how do you go about determining a subtype of dementia disclosing it in a person-centered fashion, and then implementing both community supports and pharmacological treatments. So these are just some examples of the slides we used in our education program and which are part of our course, including things like risk factors for dementia, some key ways to considerations around the disclosure, which we incorporated recommendations from the Alzheimer's Society of Canada, resources for community support such as the Alzheimer's Society, and a whole bunch of different topics. In terms of our initial education sessions, which were implemented in Ontario, and this was back when we had a little bit different health care boundaries, but in our health region, we had about 60 healthcare providers who went through our course, and overall the content was rated as being very relevant and helpful for practice. And also some qualitative research and comments indicated the tools that we had incorporated as part of the learning were really very valuable takeaways. Here's just a quick sample of the sort of the cheat sheet, and in Saskatchewan, the team working with Deborah Morgan did a really great job of integrating these cheat sheets or flow sheets into their electronic health record to sort of integrate that into clinical care pathways. And in terms of the online course, which I want to acknowledge the Alzheimer's Society of Ontario and Toronto supported the development along with the Ministry of Health in Ontario. This will be launching online April 2nd, 2021, and it's accredited for main pro credits for family doctors. And we've taken our online content from the first two modules and made two modules, each about 30 to 45 minutes, that healthcare providers can log in and take the education online. Our hope for the future is to be able to develop additional modules depending on interest in specific topics, and also to integrate more sort of regional resources for different provinces or areas in the country. We've had about 60 people go through the course, and the evaluations that we've had completed to date indicate the feedback's been very similar to the in-person education sessions that we did. And certainly if you have any questions about our program, please feel free to contact me. I'd be happy to connect with you. So thanks for your attention, and I think I'll turn it back to our moderators.
Thank you, Dallas, for your presentation today. We would like to now ask you a couple of questions. And so prior to this webinar, were you aware of PC data? Yes or no? And I know more about PC data than I did before participating on this webinar. Strongly agree, agree, neutral, disagree, or strongly disagree. I'll give you a few moments to answer those polls, and I also invite you to type any questions you have into the chat box, and we will address them shortly. And keep your comments and questions coming, and what we don't get to today, we will answer and summarize in the post-webinar synopsis that you will get in a few weeks to allow for translation. So thank you for completing the polling. I will now turn it over to Mary Beth and Mimi to share some reflections on what we have heard today. And so Mary Beth, over to you.
Thank you very much, and thank you very much, Dallas, for that very interesting presentation. And I'm going to throw I have a couple of questions here. I'm wondering if the type of reports and work that you're doing currently, if you'll be sharing it with the World Health Organization, the Global Dementia Observatory, which is, you know, international storage area really for good data about dementia, and I'm wondering if going forward, if the Alzheimer's Societies are also planning to help support your work across Canada. So just really just a few comments for you, just wondering. Thank you.
Thank you, Mary Beth. Dallas, did you want to come back and answer Mary Beth's question?
Sure. Yeah, in terms of the repository, I have to confess that I don't know that much about it, but it sure sounds interesting and relevant. And with our Alzheimer's societies, we, as we mentioned, we have partnered with the Alzheimer's Society of Ontario for the online course. We did also did some webinars here in Alberta with the Alzheimer's Society of Alberta and Northwest Territories to raise awareness. And we do see our Alzheimer's societies as being sort of key partners, and hope that while they're out interacting with their primary care colleagues, that they'll be able to sort of share some information about this resource that's available for our primary care colleagues if they're interested in learning some more about dementia assessment.
Great. Thank you, Dallas. And Mimi, we'll come back to you to have some reflections on what we've heard today and any of the comments that have come through the chat box. Mimi, over to you.
Sure. Thank you very much. Thank you very much, Dallas. I think the work that you're doing is excellent, and the importance of the spread and scale is critical. You're been focusing on Ontario, and I think that's great. I think the opportunity is to engage, as Mary Beth alluded to, the other Alzheimer's Society, provincial Alzheimer's societies, and the College of Family Physicians of Canada, and begin to try to entrench some of this learning and process, which is so critical in the care and support of people living with dementia. I would comment that the importance of relaying information to families and the individual are so critical, and I think what you have highlighted is some of the strategies and techniques to support family physicians in both the assessment and sharing the information with the individual and the family. I think that's a very important aspect of the work that you're doing and evaluating in terms of effectiveness around the education of health professionals, and also having to look at not only the primary care physician, but the healthcare team that may exist in the context of the family physician and the surrounding team that he works with or she works with. That's important to include in the ongoing support of individuals and their families. So great work. Keep it up, and let's spread and scale. I think it's important that we engage as many people, as many physicians and health teams in your process. Thank you.
Great. Thank you, Mimi. And we've received quite a few questions through the chat box. And so, Dallas, does the course include information about primary care diagnosis, support for diverse populations, example, different cultural considerations, language, people with disabilities, etc.?
Yeah, it's a great question. One of the, I would say one of the first things we want to do, right now the information is only available in English, so one of our first priorities on that front will be, to try to secure some resources to have French translation. And I think these topics about working with diverse communities and topics kind of related to inclusion and equity are really important and have surfaced a few times in our needs assessments, and I think there's probably some overarching principles that we need to look at being incorporated in all of the course materials, and also perhaps some specific modules or approaches to address those things, because they probably are not addressed as fulsome as I think we're all acknowledging now that we need to consider these topics in all of our work.
Great, thank you. And a follow-up question, can the online PC data training be accessed by all healthcare providers or targeted to physicians?
No, the online learnings, which will be launching, and it is, I apologize if this wasn't also clear, there is going to be a fee for accessing it now because we're in a sustained sort of phase where our development funding has come out. So it's available for anyone to access. However, there is it's an online course, so there's a fee to access the modules as of April 2nd. If people did want to, review the materials in advance of that, because they were thinking of working with their team on this, feel free to contact me about that. But anyone could access the materials, once they paid for the access to the online course.
Thank you. We got some great enthusiasm about how great it is to see knowledge translation from the specialist into primary care, and I appreciate the key understanding that primary care does see the majority of patients with dementia. The person is wondering if you have looked at partnering with primary care in dissemination of this. For example, Dr. Linda Lee, a family physician from Ontario with Mint Memory Clinics, models is being rolled out across Canada, for instance, and we actually received a response from Deborah Morgan in the chat box, who you mentioned you've been working with. She mentioned, we have been partnering with rural primary healthcare teams to operate memory clinics. Team members use the PC data flow sheets, which are integrated into the EMR. The flow sheets are meeting a need identified by team members for decision support tools to guide their assessments. Dallas, would you like to add anything to Deborah's response to this question?
Well, I'd like to thanks, Deborah, and she's really, and the team in the southeast of Saskatchewan. In terms of, as I'm quite aware of Linda Lee's model, actually both from an Ontario and also the implementation they're doing here, and Linda's got an excellent model. I think, part of the need our program was trying to identify was what the ministry, I think, referred to as sort of low-touch, broad-based education that might be applied a little bit more, broadly than I would say the more sort of intensive but excellent model that the primary care memory clinics employ. So, and we've also had some folks who work in the primary care memory clinics go through our education materials, and their comments have been, the approach is, there isn't a single right or wrong way to approach dementia care, but there are having a stepwise, evidence-based sort of approach that addresses the key elements of assessment are important. And the folks who've worked at the primary care memory clinics who had also gone through our information have said, it's a similar sort of idea, similar sort of approach, although the implementation and resources are applied differently, for our project compared to Linda Lee's. Hopefully that answers that question. Great, thank you, Dallas.
We also received a link from Mary Beth to the World Health Organization group that she mentioned, so I'll make sure that we pass that along to you. And some enthusiasm from Behavior Supports Ontario, who would be interested in working with you to support the education of primary care physicians. So we'll make sure you get that contact information as well. Following up on another question, is the course being promoted by the various provincial colleges of physicians?
Yeah, so the initial project was, so we had engagement with the Ontario College of Family Physicians, and we do have an advisory committee. I think we've been having some discussions with the Alzheimer's Society of Canada about trying to also partner with the work that they're leading with the needs assessment with family physicians, and then, hopefully there'll be an opportunity to sort of converge and collaborate once that work has been completed. So, we're working on developing those relationships, and certainly are interested in collaborating with more primary care organizations and professional colleges.
Great, thank you. And how have people living with dementia been involved in the training?
Yeah, so truthfully, I mean, we had people living with dementia providing input into the training materials, but not directly involved in the training. And, you know, I think in future modules, there would be really lovely to have, you know, some learnings that were directed a bit more from the person living with dementia experience, or incorporating that into the materials, because I think that really resonates with all of us as healthcare providers, and of course is our ultimate end goal is to improve care. So again, an area we'd probably like to strengthen in the future, if there's opportunities to do so.
That's great to hear, Dallas. Always great to engage with people with lived experience. Could you comment on the role of dementia care managers? Are there Canadian regions where families have access to dementia care managers? Any insights on this?
Yeah, I think Quebec did have, you know, dementia sort of resources or nurses, I believe, who were, you know, as part of some phases of their dementia strategy, which I think has been helpful. In our original project, we did also have people from the nurses I worked with in our geriatric psychiatry outreach program who were resources with primary care physicians or primary care groups, which I think was really helpful in sort of building the relationships and the seamless connections. I'm not sure that the care management model has really taken off as much as it has in the U.S., for example, which is, I think, unfortunate. I would say in some areas there are existing services that sort of fulfill those roles. So certainly some places are education coordinators or supports from the Alzheimer's Societies play many of those roles. They may work directly with primary care. They might help with sort of coordinating services. In other places, those processes might actually be managed by home care, but it's a bit patchy and not consistent across the province, or across the country, I should say.
Great, thank you for those insights, Dallas. And are you working to include supports that are available in the community or social supports in addition to the medical interventions that you're proposing in your tool?
Yeah, absolutely. Actually, I say the treatment for, you know, the most effective treatments we have for dementia are people and services. And so, you know, the first step actually after disclosure of diagnosis, which is included in the education materials, are, you know, first trying to facilitate, you know, a referral or connection to First Link, and then other services or supports that might be helpful for the individual given their specific circumstances, which may be recreational programs, it might be, you know, home care, it may be activity programs depending on the individual. So that is incorporated into the education in general. I think one of the challenges and, you know, areas that given additional resources we'd like to be able to build out is to have that, if you're signing in from British Columbia or Manitoba and you go through the training, that when you get to those sections it would actually be your local referral information or contacts for those programs that are specific to your area. So right now that's challenging to do with our, you know, current course, but that would be the vision for where we would see something like that getting integrated.
Great, thank you. So you've answered all of the questions we've received through the chat box today. I would like to thank Dallas for his presentation today. I would also like to thank Mary Beth and Mimi for their thoughtful reflections and comments. Thank you to our producers, operators, and simultaneous interpreters for their efforts in making this webinar happen. Finally, thank you to you for all for joining us today. In just a few moments, I will read out a few CQI questions, and so your answers to these questions help us plan our future webinars. Please note that our next webinar in this series will be hosted on Zoom. We will send you the new connection information by email in the coming weeks. If you do not receive this information from us in advance of the webinar, we ask that you reach out to cbd-dmc@hec-esc.ca to let us know, and my colleague Emily is going to put that email in the chat for us. So if you don't hear from us in advance of the webinar, please do let us know and we'll make sure that you get the connection information. And so now for the polling questions. Overall, I was satisfied with my webinar experience. Strongly agree, agree, neutral, disagree, strongly disagree. Overall, I was satisfied with how I was able to actively participate in the webinar. Strongly agree, agree, neutral, disagree. And do you have any comments or suggestions to improve the content shared in this webinar? Once again, thank you to everyone, and we look forward to seeing you at our next webinar in this series on April 6th, 2021. Have a great rest of your day.
This concludes today's webinar. Thank you, everyone. You may now disconnect.